So anyways, guys, the first question was 45-year-old male presents for a pre-operative evaluation for scheduled elective surgery. During airway assessment, he opens his mouth and you see base of uvula with soft palate, hard palate, and based on this finding, which Mallampati classification was given. So guys, remember, whenever the patient is opening his mouth, if you are able to see all the structures, he is class 1. Okay? If you are able to see uvula plus soft palate and hard palate, but the tip of uvula is not seen, that is class 2. If you are able to see the base of uvula, hard palate and soft palate, it is class 3. Class 3 indicates the patient is having a difficult airway. Okay, so the answer is class 3. Next, a patient with non-alcoholic liver disease is scheduled for a dental extraction. Which of the following local anesthetic can be safely given to this patient? Now guys, remember, this question is regarding local anesthetic safely given in a patient who's having some alcoholic disease. So remember guys, always amino-amides are the local anesthetic which can be safely given. Amino-amides are the local anesthetics which are usually metabolized in the liver, whereas amino esters are the local anesthetics which are metabolized in the plasma by plasma esterases. So any patient who's having liver disorder, will you give amino-amide or amino ester? You will always give amino ester. So which is the amino ester which can be safely given over here? It is articaine, 1I articaine, whereas lignocaine, bupivacaine and mepivacaine, these are all amino-amides, so you will be avoiding these drugs. Okay. Next, a patient following an RTA presents with multiple lacerations on his forearm knee region which were sutured under local anesthesia. A few minutes after suturing, he complained of lightheadedness and dizziness, which was followed by an episode of seizure. So basically, after receiving a local anesthetic, patient is complaining of seizure and dizziness. That indicates the local anesthetic has gone, or basically you have exceeded the dose, or the local anesthetic has gone intravascular. Okay? So either of the two things, either you have exceeded the dose or either it has gone intravascular. The patient is having now the features of local anesthetic systemic toxicity. So in this case, what you should give? In this case, you should give what? Whenever the patient is having local anesthetic systemic toxicity, the best is you give 20% intralipid solution. That is the best thing, guys. Okay? Apart from that, you can give the patient diazepam or you can give other things to the patient. But the main management of local anesthetic systemic toxicity is 20% of intralipid solution. Okay. Next, the anesthetist decides to administer lignocaine with adrenaline for epidural analgesia. Choose the correct pair of concentration of lignocaine and the concentration used with adrenaline. Two things you have to be clear. First is what, guys? First is basically what is the concentration of adrenaline added with lignocaine given with local anesthesia or local anesthetic. Remember, in local anesthesia, the concentration should be how much, guys? The concentration, it is always 1:2 lakh. So one thing is clear. So basically these two options are wrong, because in local anesthetic procedure, in epidural also you're using local anesthetic only. The concentration should be how much? 1:2 lakh. Now, and what he's asking, he's also asking the concentration of lignocaine. Now you are left out with option B and C. For that, I gave you the mnemonic, guys. Concentration of lignocaine used in different anesthesia techniques. The mnemonic was INETS. I stands for IVRA. Okay. N stands for nerve blocks. E stands for epidural. T stands for topical. And S stands for INETS. I stands for IVRA. N stands for nerve block. E stands for epidural. T stands for topical. S stands for spinal anesthesia. No one is answering. Okay. So anyways, in IVRA, the concentration is how much, guys? 0.5%. In nerve blocks, it is 1 to 2%. Nerve blocks and epidural, 1 to 2%. Whereas in topical, it is 2 to 4%. In spinal, it is 5% of lignocaine. So here he is asking about epidural. Epidural concentration is how much, guys? It is 1 to 2%. And 1% is given in two options. So option B is the right answer. 1% you are giving lignocaine and the concentration of adrenaline is 1:2 lakh. Okay. Next, guys. Next is what? A 37-year-old man is on surgical table for a inguinal hernia repair, which At what level of spinal cord is spinal anesthesia administered to achieve the preferred level of block? It should not be the what level of spinal cord, at what level you are giving spinal anesthesia. Remember guys, for inguinal hernia repair, what is the level that is required for over here? L1, L2, L5, S1. And remember, L1, L2 you are avoiding guys. Why? Because L1, L2 is the space where the spinal cord is ending. He's a 37-year-old man, so spinal cord in adults is ending between the upper border of L1, between the lower border of L1 and upper border of L2. So you are avoiding it. Okay? You won't be giving so so low spinal anesthesia unless and until indicated. For inguinal hernia, you go for a normal space, that is L3, L4. Guys, in the key, some of the questions, some of the answers are wrong. I am mentioning the right answers over here. Okay. So the answer is what, guys? Answer is D. Okay. Next. 27-year-old male diagnosed with testicular torsion, scheduled for emergency surgery during pre-anesthetic assessment. The type of anesthesia was decided. Basically, torsion test is spinal anesthesia you will be given. Which of the following needle? Which of the following about the needle used for administration the necessary anesthesia is incorrect? So basically guys, remember, for testicular torsion we are using spinal anesthesia only. And what is correct regarding the needle which is shown over here is what, guys? It is a dura separating needle. Okay, dura separating needle. In this dura separating needle, what we need to remember is, why do you use a dura separating needle over dura cutting needle? Because it creates a smaller site puncture, less chances of post-dural headache if there is a small puncture, and it is commonly used in spinal anesthesia. It's not a dura cutting needle. If it was a dura cutting needle, there would be a higher chances of headache and all. So the incorrect answer over here is what, guys? It is a dura cutting needle. No, it is a dura separating needle. Okay. Now guys, question number 7. 30-year-old female undergoes spinal anesthesia for cesarean section. 20 hours later, she develops occipital headache that worsens when standing up and improves while lying down. Which of the following is a definitive treatment for her condition? First of all, she is now having post-dural puncture headache which is occurred to her as a result of, it might be the anesthetist might have used a dura cutting needle. Due to that, the patient is having headache. Now he is asking for the definitive management. Remember guys, the best management or the best management is conservative management. In conservative management, you will be giving caffeine or coffee to the patient. You will be giving IV fluid to the patient and all. But remember, that's not the definitive. The definitive management is just close the puncture that is causing headache. That is by epidural blood patch. So the answer is what, guys? Answer is C, epidural blood patch. Now coming to the next question. 65-year-old patient, 65-year-old male scheduled for foot and ankle surgery under spinal anesthesia is unable to raise his leg or move his knees. To ensure adequacy of sensory block, at which dermatome you should give the spinal anesthesia, and what is the motor blockade according to the Bromage scale? First of all, guys, foot and ankle surgery, will you give L2, L3 anesthesia? Remember, guys, will you give L4, L5, L2, L3, or you will give, will you give L2, L3 or L4, L5? When the surgery is of the foot, okay, foot means you can go for a very low space also. L5, S1 also you can try. So basically you can go for L4, L5. So over here, for foot surgery, spinal anesthesia is given at what level? L4, L5. So L2, L3, these two options I am ruling out. We are now left with two options which are indicating L4, L5 space. Now, according to the Bromage score, what is the patient? Remember, guys, the patient is unable to raise his leg or move his knee, but he is able to move his feet. Now, according to the Bromage, guys, remember, when you give Bromage 1, when the patient is unable to move feet, yani he is not at all able to move his knee, feet, anything, that is Bromage 1. Bromage 2, when do you say it is almost complete only, almost complete block, yani patient is just able to move his feet. Bromage 3, patient is able to move his knee. Okay? Bromage 4 means what? Patient is flexing his leg properly. That is bromage 4. So bromage 4 means there is no effect at all. Over here, the patient is just able to move his leg. So it is the bromage score. So the answer over here is what? We are giving spinal anesthesia at L4, L5 and the bromage score is 2. Why? Because the patient is moving his feet. If he was not moving his feet, it was bromage 1. Okay. Next. A 75-year-old male with osteoarthritis is undergoing hip replacement surgery after obtaining proper consent and following necessary precautions. The catheter was inserted successfully. What is the most likely factor that could hinder the administration of epidural anesthesia in this patient? Remember guys, as the patient is having old age, in old age, what happens to the epidural space? Okay? There is no increase in the intra epidural venous pressure, no decrease in the epidural venous pressure. But what is happening in old age is there is narrowing of the epidural space that makes it difficult to put the catheter also. Okay, so narrowing of epidural space could be seen in old age. Next, a 3-year-old boy is scheduled for circumcision and is undergoing pre-anesthesia evaluation. Which type of anesthesia is preferred for this procedure? Guys, remember a 3-year-old boy posted for circumcision. The best thing that could be given to this patient is spinal general local caudal. Remember, the best could be caudal anesthesia where you are inserting the needle at the level of sacral hiatus. Okay? And while inserting the needle, the last layer to be pierced in caudal anesthesia is the sacrococcygeal ligament. Sacrococcygeal ligament. Okay. So anyways, guys, remember that is basically the best for 3-year-old child. But what we are doing in our practice is normally the parents are not agreeing for. They will be telling, don't give any injection to our child at this age group. At back, don't give any injection. There will be problems. Parent will be telling. So for those parents and all, we are nowadays we are doing most of the circumcisions under general anesthesia also. General anesthesia means under sedation. Okay. So anyways, guys, but for theory purpose, best is what? Caudal anesthesia. Okay. Now, 2-year-old child who's weighing 10 kg scheduled for a procedure that requires caudal anesthesia. The anesthetist planned to use 0.1% of lignocaine. The recommended dose is set at 0.5 ml per kg. What is the total volume of lignocaine that needs to be administered? That is very simple, guys. He has given you two things. The weight of the child is 10 kgs and how much he has also formulated. How much should be given? 0.5. 10 into 0.5 is how much, guys? 5 ml. 5 ml of total lignocaine can be given to this child. Next, a patient undergoing rapid sequence induction of anesthesia receives succinylcholine as a muscle relaxant. After shortly administration of choline, anesthesiologist notices muscle fasciculation followed by flaccid paralysis. Basically, I told you, while giving succinylcholine, you will see what succinylcholine is a muscle relaxant. But initially, what happens? Initially, due to the prolonged depolarization of the muscle membrane, patient will have fasciculations. And then what will happen? Depolarization stops, action potential stops, and then the muscle becomes light. So remember, these fasciculations are seen due to prolonged depolarization of the muscle membrane. Other options, why they are wrong? Because remember, competitive inhibition of acetylcholine at the neuromuscular junction, it is not the feature of succinylcholine. Remember, this is caused by non-depolarizing muscle relaxant. Okay. Rapid hydrolysis by acetylcholinesterase, no, that is also a wrong thing, guys. Okay. A 45-year-old woman with a history of myasthenia gravis is undergoing an emergency appendectomy. The anesthesiologist is planning for rapid tracheal intubation. The patient is currently on pyridostigmine. Which of the following is most appropriate muscle relaxant of choice for this patient? Come on, guys. What should be given for this patient? So anyways, guys, we are discussing about what? A patient of myasthenia gravis. So guys, remember why I have written RDN. Remember, patient of myasthenia gravis, they are resistant towards depolarizing muscle relaxant and sensitive towards non-depolarizing muscle relaxant. So over here, remember, if you give succinylcholine at a standard dose or a reduced dose, they are resistant to it. Okay? Pancuronium, you're not giving. Pancuronium is a longer acting muscle relaxant. They are sensitive to non-depolarizing muscle relaxant. So you don't give pancuronium. Instead of pancuronium, you give a rapid acting muscle relaxant that could act easily and that could finish its action easily. So what is the answer over here? Answer is rocuronium. Why? Because with rocuronium, we are having a reversal agent called as sugammadex, which can easily reverse the patient from the effect of rocuronium. Okay, so remember, these patients are resistant towards the depolarizing muscle relaxant and sensitive towards what, guys? Non-depolarizing muscle relaxant. Okay. Next, question 14. A 45-year-old male is undergoing surgery and is given repeated dose of succinylcholine or succinylcholine for muscle relaxation. That is a very bad thing. Repeated dose never you give. If you give repeated dose, what will happen? Repeated dose of choline will cause a phase 2 block. Okay. So which of the following is not a characteristic feature of a phase 2 block? So remember guys, not a characteristic feature. First we'll discuss. It is associated with a fate. Remember, whenever you are giving choline to the patient and you go for a train of 4 stimulation, you will see a train of 4 ratio of 1. Yani there is no fading. Fading is always seen in non-depolarizing. But over here, you have given succinylcholine repeatedly. Repeated use of succinylcholine will make a block similar to a non-depolarizing muscle relaxant. That's why you will see what? You will see a fading over here. So it is associated with fading. That is a right thing. Next, it can be influenced by prolonged exposure to succinylcholine. Yes, phase 2 block will be influenced by exposure to succinylcholine. You have to stop giving choline. Okay. Next, fast twitch fibers are more susceptible in phase 2 block. That is also true. But remember, it does not respond predictably to cholinesterase inhibitor like neostigmine. In phase 2 block, if at all phase 2 block happens, what is the best thing? You just ventilate the patient till he spontaneously recovers. But if he is not spontaneously recovering, you can give neostigmine, but you cannot predict how it will act and all. Okay. But remember, giving neostigmine is not the first choice in the patient who's developed a phase 2 block by succinylcholine. Best thing is you need to just wait for the patient for him to spontaneously recover from the effect of choline. Next, guys. 28-year-old man is with a history of asthma is undergoing elective surgery. He is induced with isoflurane and succinylcholine for muscle relaxation. Okay. Within minutes, the surgical team observes that he has developed muscle rigidity, rapid heart rate. Basically, they are asking about what, guys? Malignant hyperthermia the patient has developed. Now, which is the drug responsible for this patient? Remember, guys, malignant hyperthermia can be caused by many drugs in anesthesia. Lignocaine can cause malignant hyperthermia. In muscle relaxant, succinylcholine can cause malignant hyperthermia. Whereas in inhalational agent, almost all inhalational agent can cause malignant hyperthermia. So, what's the answer over here? Isoflurane and succinylcholine both will cause malignant hyperthermia. So ideally what we should do, stop both of these agents, give 100% of oxygen and prepare a dantrolene sodium. That should be the ideal answer for the management of malignant hyperthermia. Coming to the next question, guys. A 45-year-old patient presents to the emergency department with altered mental status, flushed skin and tremors after starting a new antidepressant. Okay. On examination, there is hyperreflexia in the lower extremities, muscle rigidity and clonus. Which syndrome should be considered in her case? Guys, remember, first we will rule out why it cannot be malignant hyperthermia. Why it cannot be malignant hyperthermia? Why? Because there is no mention of any anesthetic agent over here. So, no anesthetic agent mentioned. That's why we are directly ruling out malignant hyperthermia. They have not mentioned any surgery also. If some surgery, during surgery means, if they have not mentioned any anesthetic agent and during surgery something was given, then we would have thought about it. But malignant hyperthermia means they should be mentioning of some anesthetic agent or the surgery. Okay. Next, why it cannot be neural malignant syndrome? Because remember, guys, in the question it is asking about hyperreflexia, whereas in neural malignant syndrome there is hyporeflexia. This cannot also be a heat exhaustion. Why? Because heat exhaustion usually does not present with neuromuscular symptoms like clonus or hyperreflexia. So In the question, they have mentioned a new antidepressant and then the patient is developing the symptoms. The answer is what, guys? The answer is serotonin syndrome. Those are all features of serotonin syndrome. Next, a 24-year-old male with no significant medical history is scheduled for a minor surgical procedure. The anesthesiologist administers remimidazolam for sedation. What is the primary advantage of remimidazolam? Remimidazolam is nothing but remimidazolam over midazolam in this setting. Remember, guys, whether it is remifentanil, remimidazolam, okay, whenever remi is added, that means it is added to the drug to make it more rapid. So the answer over here is basically it is having more advantage over midazolam. Why? Because it's more rapid and consistent recovery profile when compared to midazolam. Next, 40-year-old male with hypertension undergoes fiber optic intubation. After receiving loading dose of dexmedetomidine for sedation, his heart rate drops to 45 beats per minute and his blood pressure slightly increases. What explains this changes? Come on, guys. When you have given dexmedetomidine to the patient, what is happening is basically BP is increased and the heart rate has decreased. That is basically initial increase in the BP followed by a reflex bradycardia. That is basically patient is having a reflex bradycardia. Okay, with dexmedetomidine, we see this. Dexmedetomidine is used for conscious sedation. For NORA is nothing but non-operating room anesthesia. We can use dexmedetomidine. Okay. Next, which of the following anesthetic agent is ordered from the lowest to highest in terms of MAC values indicating the potency? Remember, guys, MAC indicates the potency and low MAC is equals to high potent drug. Low MAC is equals to high potent drug. So I told you regarding the MAC values, the mnemonic is what, guys? The mnemonic is HISD, low MAC to high MAC. Okay? If you go in the opposite direction for HISD, you will get DSIH. This is the mnemonic for what? This is the mnemonic for blood gas partition coefficient. Low blood gas coefficient to high blood gas coefficient. Low blood gas to high blood gas coefficient. So guys, low MAC to high MAC, what is that? Halothane, isoflurane, sevoflurane and desflurane. Okay? So over here, what's the answer? A, B, C, D. It is halothane, isoflurane and desflurane. That is going low MAC to high MAC. Okay. Next, a 45-year-old woman with a history of moderate alcohol undergoes general anesthesia for emergency appendectomy. The anesthesiologist uses halothane for induction and maintenance. Don't know why he used halothane for induction. When you are having many drugs available, you don't use halothane for induction. Normally for induction, if you are using, you can use sevoflurane, but halothane can also be used. Okay. So anyways, 2 weeks after the surgery, patient presents with fatigue, nausea, jaundice and tender hepatomegaly with AST, ALT, total bilirubin, direct bilirubin, all elevated. That is a classical case of some liver injury. But this liver injury is caused by what? What is the thing that has caused liver injury in this patient, guys? It is basically a direct hepatotoxic of halothane or immune mediated. Remember, guys, halothane produces hepatotoxicity by causing immune mediated hepatotoxicity. Remember, halothane 4 H's. 4 H's of halothane. It is not direct, it is immune mediated hepatotoxicity. 4 H's of halothane is what? First H is halothane can cause hyperthermia. Remember, in inhalational agent, almost all will cause malignant hyperthermia, but maximum incidence is seen with halothane. Next, hepatitis. Next, halothane is contraindicated in heart disease. Okay? Contraindicated in heart disease. Hepatitis, it causes immune mediated hepatitis. Next, halothane has 2 maximums. What 2 maximums? Maximum bronchodilation and maximum muscle relaxation can be seen with halothane. So these are the points of halothane that we need to cover. Now coming to the next question, guys. A 45-year-old chronic alcoholic patient scheduled for emergency laparotomy. The preoperative peripheral blood smear is shown below. We don't have to do anything with the smear. Okay? Exposure to which of the following anesthetic agent is most likely to precipitate the subacute combined degeneration of the spinal cord? Subacute combined degeneration of the spinal cord can be seen with which agent? It is always with nitrous. Nitrous usually inhibits the vitamin B12 dependent enzyme. Okay, vitamin B12 dependent enzyme that leads to subacute combined degeneration of the spinal cord. Next, which of the following inhalational agent has lowest blood gas partition coefficient, thereby ensuring the fast induction and recovery? Once again, guys, low blood gas coefficient. Remember, low MAC to high MAC, what was the mnemonic? You just have to be very fast. Low MAC to high MAC, mnemonic was HISD. Then in the opposite direction, you will get DSIH. That is for what? Low blood gas to high blood gas coefficient. Which is having low blood gas coefficient? D से हो गया desflurane, S से हो गया sivo, I से हो गया iso, and H से हो गया halothane. Low blood gas meaning what? It will be having fast onset and fast recovery. Fast onset and fast recovery. So what's the answer over here? It is desflurane. 0.47 is the blood gas coefficient of desflurane. That makes it the fast onset and fast recovering inhalational agent. Next, guys. During a surgical procedure, the anesthesiologist is monitoring the patient and observes a complete respiratory depression, total loss of reflexes, and dilated non-reactive pupils. According to the Goodell's stages of anesthesia, which stage is most likely the patient in? Stage 1, stage 2, stage 3, and stage 4. Right? Guys, remember, the patient is in complete respiratory depression. So the answer over here, before going to the answer, we need to understand Goodell's stages of anesthesia. Stage 1 means analgesia. Stage 2 means delirium. Stage 3 is the stage required for surgical anesthesia. Stage 4 means now the patient is having respiratory paralysis, or stage 4 could be seen in cardiac failure or death. Over here, the patient's reflexes are gone. Respiratory depression is seen. So it is the stage 4 of anesthesia. Stage 4 of anesthesia. Okay. Which of the following statement best describes the second gas effect of nitrous oxide when administered with isoflurane? Guys, remember, with nitrous oxide, you will see a thing which is called a second gas phenomena. Second gas phenomena is what? As nitrous is having a high MAC value of 105, we cannot use nitrous as a sole gas. We use nitrous with some other gases. What will it do when we give nitrous with some other inhalational agent? That nitrous will basically increase the concentration of those inhalational agents in the alveoli. So basically, remember, guys, what's the answer over here? Second gas effect means what? Nitrous, when you are giving with isoflurane, it will increase the concentration of isoflurane in the alveoli. Neither it will decrease nor it will increase its own concentration. No. Okay. So the answer over here is B. Next, a 50 kg patient who has been fasting for 6 hours before surgery. The maintenance fluid rate. Okay. He has already given the maintenance fluid rate, which is 1.2 ml. Yani already calculation has been done. Already 4:1 has been done, and he has given a value of 1.2 ml per kg per hour. What is the fluid requirement for this patient? When he is given all these things, just you have to formulate it. 1.2 into 50 into how many hours of fasting? 6 hours of fasting. 1.2 into 50 is equals to how much, guys? It is 60. And 60 into 6 is equals to 360 ml. So answer is what, guys? 360 ml should be given. Okay. Next, a 45-year-old male undergoes abdominal surgery and requires fluid replacement. The patient has history of chronic kidney disease. Which of the fluid is most appropriate for maintenance during surgery to avoid the risk of hyperchloremic metabolic acidosis? First of all, which is the fluid that causes the risk of hyperchloremic metabolic acidosis? It is always the 0.9% normal saline. If you give, then it can cause risk of metabolic acidosis. And which is the best fluid to be given to this patient? It is Ringer's lactate. Ringer's lactate is the best one. Okay. Hyperchloremic, remember, normal saline should be avoided, right? Ringer's lactate should be given. Next, A 50-year-old patient is scheduled for a short elective procedure in a daycare setting. The anesthesiologist needs to ensure rapid induction, short-term muscle relaxation, and quick recovery to facilitate the early discharge. Which muscle relaxant would be most suitable in this scenario? Vecuronium, succinylcholine, mevaquarium, pancuronium. Remember guys, the patient is for daycare surgery. In daycare, you need to go for a short-acting muscle relaxant with less side effects. Vecuronium is an intermediate acting, that is ruled out. Pancuronium is a long-acting muscle relaxant, so these two are ruled out. We are left out with two short-acting muscle relaxant, Meva and succinylcholine. Remember, the shortest of all is what guys? The shortest of all is succinylcholine. We can give succinylcholine, but again, the patient is in a daycare setting. If you give succinylcholine, then after discharge and all, the patient will be complaining of muscle ache and all. Why? Because succinylcholine has the side effect of hyperkalemia, muscle soreness. So instead of succinylcholine, go for the other short-acting non-depolarizing muscle relaxant, that is mevaquarium, which is having less side effects. The reason why you're using mevaquarium is it is having less side effects. Not it is more shortest than succinylcholine. Succinylcholine is the most shortest, but having side effects. Next, a 35-year-old asthmatic patient is scheduled for a minor surgery. Which induction agent and muscle relaxant is safest for this patient? So basically, asthmatic patient, you have to avoid those agents which can release histamine or which can precipitate or which can worsen the asthma. So basically, you can give propofol to the patient, but at the same time, you cannot give scoline to the patient. Okay, it releases histamine. So this cannot be the answer. You can give ketamine to the patient, yes. Okay, but at the same time, you cannot give D to curare. Why? Because it also releases histamine and worsens the asthma. How about ketamine and vecuronium? Yes. You can give ketamine and vecuronium to the patient. Okay, ketamine is a bronchodilator and vecuronium also, it does not release histamine. So that can be given. Sodium thiopentone cannot be given. Why it cannot be given? Why? Because sodium thiopentone releases histamine. So our answer is, which of the following IV induction agent of choice in a patient with decompensated cirrhosis? A patient with decompensated cirrhosis. My answer should be what? Basically, the answer should be, I will use an IV induction agent that can be safely given in daycare surgery. When I am writing daycare surgery, remember which is the IV induction agent of choice for daycare surgery? Propofol. Whenever I am writing propofol, remember daycare surgery, if the patient comes to me, I will put a ET tube or LMA, I will put a laryngeal mask airway. Should I give him a full anesthesia, which is a combination of like using inhalational agents, or can I go with TIVA? TIVA would be better. TIVA is nothing but total intravenous anesthesia. So in daycare surgery, I use LMA, I use TIVA. Next, in daycare surgery, I will give a drug to the patient which is having antiemetic property as well as antipruritic property. Okay, antiemetic as well as what guys? Antipruritic property. In daycare surgery patient who's posted in a patient who's posted for daycare surgery, I will give a drug which is free from any side effects of liver disorder. It can be safely given in liver disorder, which is free from any side effect of malignant hyperthermia, or which is free from any side effect of acute intermittent porphyria. So all these are belonging to what? Propofol. So propofol can be given in daycare surgery for LMA insertion, for TIVA, for it's having antiemetic property, antipruritic property, given in liver surgeries, liver disorders, safely given in malignant hyperthermia and intermittent porphyria. The answer is what guys? Propofol, as the patient is having what? Decompensated cirrhosis. Remember, daycare surgery is not related to your cirrhosis. Okay? I am just telling you to remember for propofol daycare surgery so that all the points of propofol can be easily covered. Next guys, which combination of ECG is considered the best for diagnosing intra-op myocardial ischemia? Remember guys, intra-op cardiac monitoring. For that, what are the leads which are commonly used? It is the lead 2 and lead 5. Usually arrhythmias are detected by lead 2 and ischemias are detected by lead 5. So the answer over here is what guys? Intra-op means you can go for lead 2, V4 and V5. The answer is B. Okay. Next is what guys? Which of the following is the correct function of the shown image? Now the shown image or the given image is of what? It is the image of central venous catheter. This central venous catheter is used for monitoring the intracardiac pressures. It is also used to infuse solutions, okay, and measure the temperature. Okay, so the answer for this is all of the above. To measure the central venous pressure and all, you can use this. Okay, there are many sites for placing central line. You can place in the internal jugular vein. You can place in the this thing subclavian. Okay, you can go for femoral also. Most commonly, we are going for IJVs, which is the most hygienic, which reduces the chance of infection. Subclavian insertion, which is the root of central line insertion, which causes much chances of infection. Always femoral. Okay. Next, which of the following is the incorrect statement for the image given below? Okay. Next, what is the options? First, elevated EEG seen with ketamine. Yes, with ketamine and with nitrous, you will see elevated EEGs. Whenever the patient is having COPD, in COPD, carbon dioxide rises and the patient might be having hypoxemia. You will see a depressed EEG activity. Now, regarding this, remember guys, EEG is nothing but, remember what is this? This is nothing but BIS monitoring, bispectral index, that calculates the sum of EEGs. You will get values ranging from 100 to 40. 100 means patient is awake and 40 means patient is deep. Okay, so the higher the value means the patient is awake. So that is the incorrect statement. Next, which of the following is most common muscle combination tested? Come on guys, what's the answer for this? What's the answer for this? ABCD. It is basically the train of 4 monitoring. In the train of 4 monitoring, it is the, come on, ulnar nerve and adductor pollicis. Ulnar nerve and adductor pollicis. Okay, we give 4 twitches and all, and then we are testing. Remember, for if the patient is having if the patient is under the effect of depolarizing muscle relaxant, you will see a train of 4 ratio of 1. Why? Because all 4 twitches of reduced on equal intensity, reduced height could be seen. Whereas train of 4 ratio in the case of non-depolarizing muscle relaxant, the train of 4 ratio is how much, guys? It is less than 0.4. Anyways, okay. Next, a 65-year-old male is undergoing a major abdominal surgery, and after induction, the patient's CVP is at around 3 centimeters of water. The patient's heart rate is 110, blood pressure is 80/50. Which of the following is most appropriate initial management step based on CVP and clinical findings? Now guys, for this, what we need to do? The patient is having a blood pressure of 80/50. Yani you have just started and he's posted for major abdominal surgery. In major abdominal surgery, third space loss, you are basically expecting a high amount of volume loss. So you have to, and you will see whenever in major abdominal surgeries, after induction, you will see the BP falling. The first step is what? Best, and the first step is what? You give an administration of fluid bolus. Okay? That would help to increase the BP. That is the main thing, guys. For major abdominal surgeries, you have to give fluid bolus. If still not, the BP is not increasing, then the second step is you can go for administering the vasopressors. There is no need of blood transfusion unless and until in the case there is mentioned that the patient is having some blood loss. Okay. And no need to increase the depth also. Already the BP is low and all. So no need to increase the depth. So normal CVPs should be how much, guys? It should be 8 to 12 centimeters of water. His CVP is 3. It is critically low. So give good amount of fluid to the patient. Next, which of the following is incorrect about the given image? A, B, C, D. Come on, guys. Which is incorrect? First of all, D represents the best reflection of alveolar carbon dioxide. Yes, D is nothing but angle beta. Okay. Where you are measuring the carbon EtCO2. B to C represents the alveoli, represents carbon dioxide of the alveoli mixing with the upper airway. Yes, B to C, you will see that. Basically, remember guys, we are talking about what? We are talking about the end tidal carbon dioxide graph. Okay. A to B represent dead space ventilation. Yes. A to B is dead space ventilation. It is it is an inspiratory baseline. Basically, remember guys, A to B is inspiratory baseline or the dead space ventilation. Okay. Then B to C is phase 2, which is nothing but expiratory upstroke. Expiratory upstroke. C to D is nothing but the phase called as alveolar plateau. And then there is one angle between B and C, an angle called as alpha, and D and E, C and D, one angle is called, which is called as beta. So remember guys, A to B represents the dead space ventilation. Yes, that is also true. E is the value seen on the monitor. That is totally false, guys. Remember, the value that you see on the monitor is basically 35 to 45 mm of Hg. That is reading on D. This is nothing but D is representing the angle called as beta. The value that you see in the monitor is D. The marker D, not E. Okay. A 30-year-old man collapses and he is unresponsive. After tapping on shoulders and getting no response, what is your next step? If the person is unresponsive, what is the next step? No response. Basically, remember, we are talking about what? SCCS. S is what, guys? Whenever you see any patient suddenly collapsing, first what you need to do? You need to go secure the scene safety. First is scene safety. Second is what? Check for response. If he is not responding, the third is what? You call for help. Call for help, which is your answer. Next, after calling for help, then you check for the pulse and breathing. Pulse and breathing. No pulse, no breathing. Then you start your CPR with CAB protocol. Okay. So the answer is shout for help. Next, 30-year-old man is found unconscious after a motorcycle accident. There is no signs of external bleeding, but you suspect head or neck injury. You need to open his airway to check for breathing. What is the preferred method for opening the airway in this situation? Guys, remember, if you are suspecting neck injury, never you go for head till chin lift. If you go for head till chin lift, you are breaking the spine and patient will die on spot. What you need to do over here, you need to go for jaw thrust. For opening the airway, you need to go for jaw thrust. Okay. Next. 55-year-old man collapses at the shopping mall and the bystanders are performing CPR. An AED is brought to the scene, and after applying the pads, the AED analyzes the rhythm. You are assisting the resuscitation. What action should you take during the AED analysis? Will you check for the pulse? Will you continue compressions? Will you give breaths? Nothing doing. Whenever there is analyzing of the rhythm and whenever you are delivering shock to the patient, do not touch the patient. Stand clear of the victim. Okay? Stand clear of the victim. AED machine will only analyze the rhythm and if required, it will deliver the shock. If you are touching the patient, you will also receive the shock. In pediatric life support, which of the following is the most recent modification which is recommended by AHA to improve the resuscitation outcome in the children? Start airway breathing compression. That is totally false. Pulse check for 30 seconds before initiating CPR. By 30 seconds, never ever. Pulse check should be done only for 10 seconds or less than 10 seconds. Okay. Next, delivering chest compression at a depth of 1 centimeter for infant. 1 centimeter depth of chest compression, it's basically you don't give compression. It's 1 centimeter is nothing but you are not giving compression at all. The depth of chest compression in infant should be how much, guys? 1.5 inches or 4 centimeters. Whereas more than 1 year, the depth of chest compression in more than 1 year, it should be 2 inches or 5 centimeters or 1/3 of anterior posterior diameter of the chest. So the correct is what, guys? Shifting to resuscitation sequence to chest compressions, airway and breathing. CAB should be performed. Okay. 55-year-old male is found unresponsive and without a pulse. Emergency responders are activated and advanced cardiac life support is initiated. Which of the following steps should be prioritized immediately after confirming cardiac arrest? Should you give adrenaline? No. Immediately, once there is no pulse, no breathing, immediately start a high quality chest compression that will improve the outcome of the patient. Okay, so that should be the answer over here. Initiate high quality chest compression at a rate of 100 to 120 compressions per minute. 35-year-old woman presents to the emergency department with palpitation that has started suddenly and 30 minutes ago. Okay. She reports feeling lightheadedness, but there is no chest pain, shortness of breath, and her heart rate is 180. The blood pressure is 120/80. Saturation is 96. Which is the most appropriate initial management? Come on, guys. What should you give? The patient is having tachycardia. That is for sure. We have to first identify the patient is having a stable tachy or unstable tachy. Guys, remember stable tachy and unstable tachy. What is it meant by? Remember here in this patient, what are the signs of unstable tachycardia? If the patient is having hypotension, HASIA signs, guys, hypotension, altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure. Is she having any of the signs? No. So if there is no signs of HASIA, I have already told you, HASIA signs are the signs of unstable tachy. Okay? If there is no HASIA signs, then it is regarded as stable tachycardia. As in this patient, BP is fine, patient is fine, everything is fine. Okay? So in stable tachycardia, you have to go for VABC. V stands for what? The best first thing is what, guys? Vagal maneuver. Is anything given? Yes. Perform carotid sinus massage. That is vagal maneuver you have to give. If that fails, then you need to go for adenosine. First dose is 6 milligram. If does not, then you have to give 12 milligram of adenosine. B is for beta blocker and C is for what, guys? Calcium channel blocker. So guys, remember what's the answer over here? The answer over here is performing a carotid sinus massage. In the question, there were signs of instability and unstable tachycardia. The immediate answer for unstable tachycardia is what? Treatment of choices. You need to go for synchronized cardioversion. Synchronized cardioversion. 65-year-old patient with CAD and heart failure presents to emergency department with lightheadedness and syncope. He is having a heart rate of 43 and blood pressure of 80/50. The ECG is given below. He remains hypotensive and symptomatic despite IV administration of maximum dose of atropine. What is the next best step in management of the patient? Remember, the patient is having bradycardia. Okay? In this patient who's having bradycardia, what is the next step? Remember, the best management of bradycardia is you give the patient atropine. Okay? How much of atropine should be given? 1 milligram, maximum 1 milligram repeated every how many minutes? Repeated every 3 to 5 minutes, and maximum of 3 mg should be given. If that is not working, then you have to go for bradycardia. Always remember, ADE is the management of bradycardia. D stands for what, guys? If atropine is not working, then you need to go for dopamine IV infusion. Okay? You have to go for dopamine IV infusion. If that is also not working, then you have to go for what? Then you have to go for epinephrine. Okay? Then you have to go for epinephrine. That is the next thing. And if these all are not working, then you have to go for transcutaneous pacing also. Okay? So that's the answer for this. Next. 58-year-old man is found unresponsive and pulseless at home. Paramedics initiate CPR and provides bag mask ventilation. Upon arrival in the emergency department, the patient is intubated and IV access is delayed due to difficult peripheral access. IO access is not immediately available. Decision is to administer the drugs to the endotracheal tube. Which of the following drug is appropriate for endotracheal administration during cardiac arrest? Remember, guys, through endotracheal tube, the drugs which can be safely given are lean drugs. Lean stands for what? You can give lignocaine safely. You can give epinephrine. You can give atropine. You can give naloxone. But over here, the patient is in cardiac arrest. You have not started any drug. The drug of choice for cardiac arrest that should be given in these four is what? It is epinephrine. Next is what, guys? Which of the following safety features of Boyle's anesthesia machine reduces the supply of other gases in response to drop in oxygen pressure? Come on, guys. What is the answer for this? A, B, C, D. Come on, what's the answer? Remember, second stage pressure regulator, second stage pressure regulator, it is a safety feature which usually gives a signal when there is reduction in the pipeline, reduction in the flow of the pipeline. Oxygen failure supply alarm, it is an alarm that usually occurs when there is drop in oxygen. What he's telling is, which is a safety pressure, which is a safety feature of Boyle's machine that reduces the supply of other gases, which is a safety. Basically, remember, during anesthesia, you are giving nitrous, you are giving halothane, you are giving oxygen. Whenever oxygen supply reduces, it is this thing called as oxygen failure safety device, which will reduce nitrous, which will reduce halothane, so that the minimum oxygen which is there in the machine goes to the patient without other gases. So the answer over here is oxygen failure safety device. Match the gas to its respective cylinder and shoulder colors. Okay. Oxygen, what is the color, guys? Oxygen shoulder color is what? Body and shoulder color. So it is only body color given. Oxygen is black body and white shoulders. So oxygen, a black body, white shoulder. Okay. Nitrous, what is a body color, guys? Nitrous body color is complete blue. Nitrogen is what? Nitrogen is black in color. Carbon dioxide is gray in color. Entonox cylinder, Entonox is blue body, white shoulders. Okay. Air cylinder is black body, white shoulders. Air cylinder is white body and black shoulders. But in other countries, the color of air cylinder is gray body and black and white shoulders. Gray body and black and white shoulders. So the correct combination is A. Correct combination over here is A. Okay. Next, match the following column A with column B. So first of all, he's asking basically the pin index system. I'll write the pin index system over here. Guys, remember what is the gas over here which is shown? It is blue body, white shoulder. Blue body, white shoulder means it is Entonox. The pin index system of Entonox is 7. Okay, 7. Next, this is what, guys? Black body, white shoulder. It is air. The pin index system for air cylinder is 1,5. Next, it is complete blue. Complete blue means nitrous. The pin index system is what, guys? 2 molecules of nitrogen. Remember, nitrous we write as N2O. 2 molecules of nitrogen and 1 molecule of oxygen. So it is 3,5. The pin index system is 3,5. Whereas this is what complete gray cylinder is of carbon dioxide. Carbon dioxide pin index system is 1,6 or 2,6. So the answer over here should be what? Basically, he has given many options. Answer should be 1E, 2A, 3D, 4C. 3 is not D. 3C. Okay? So basically this is the option. 3 is C and 4 is what it is. 4 is D. Okay, 4D. This is the right combination, guys. In the they are circular bobbin and there is a cylindrical bobbin. Circular and the cylindrical bobbin. So he's basically asking you which is right. Basically where by reading at what by looking at the which part of bobbin you can tell that this is the flow rate of the gases which is being given to the patient. So what's the right answer over here, guys? Remember, if it is a circular bobbin, you have to look at the top of the bobbin. If it is a cylindrical bobbin, remember, cylindrical bobbin is usually like this. Okay? Cylindrical bobbin, it is parallel with the equator, and circular bobbin, you have to look at the top of the bobbin. That will indicate the flow rate of the gas. Okay? This bobbin is made up of what? This bobbin is made up of aluminium. Bobbin indicates the flow rate of the gas. So answer is A. Choose the correct set of true statement regarding the central supply and diameter index safety system. Guys, remember first of all, what is diameter index safety system? Diameter index safety system is a system that prevents the wrong attachment of the pipeline Okay, not wrong attachment of the cylinder to the machine. Wrong attachment of the cylinder to the machine is done by pin index system, not diameter index safety system. In diameter index safety system, which of the following are true? Come on, guys. What are the two statements which are true? Diameter index safety system. This is used for preventing wrong attachment of the cylinder to the machine. No, it is basically the pin index system that prevents. So that is false. Next, white color hoses are used for oxygen. Yes. Remember, guys, the pipeline color. The pipeline color of the pipeline color is basically the shoulder color of the gases. Oxygen shoulder color was oxygen cylinder shoulder color was what? White. So the pipeline color would be white. So next, it is a part of low pressure system. Yes, that is also right. It is a part of low pressure system. Ideal pressure of the gases is fixed at 45 psi. No, ideal pressure is never fixed at 45 psi. It should be 50 or less than 55, but it is not fixed at 45 psi. So answer over here again is what, guys? 2 and 3 are the right options. Regarding the diameter index safety system, guys, remember the pipeline colors they could be asking you. Pipeline of oxygen. Remember, oxygen cylinder color was black body, white shoulders. So take the shoulder and you will take over here, you will get a pipeline color. Okay, that is white in color. Pipeline. Okay, next, after oxygen, next nitrous. Nitrous, what is the shoulder color, guys? It is blue. So pipeline color is also blue. Next, oxygen is there, shoulder is there, air. Air, what is the pipeline color? What is the shoulder color of the air? Air is basically white body and black shoulder. So pipeline is black in color. Vacuum. 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 We add a stroke, it becomes Y. So it is yellow in color. Yellow in color. Next, you notice the following vaporizer being used in the operation theater, which is a likely anesthetic agent that could be used over here. What is the vaporizer which is given over here? Blue vaporizer indicates that it is desflurane. Desflurane, right? Isoflurane vaporizer color is purple in color. Okay. Sevoflurane. Sevo, remember, Sevo is sweet. Sevanya. Sevanya, you have to remember. Sevo means Sevanya. Sevanya is sweet dish. And what is the color? Yellow. So Sevo is stored in yellow color vaporizer. Halothane. Halothane. Hell means hellfire. Red in color. Next. Which of the following is a standard breathing system for pediatric patients up to 25 kgs? Remember, breathing circuits are Mapleson breathing circuit, Mapleson A to F. Okay? Mapleson A breathing circuit is also called as Magel circuit, which is the circuit of choice for spontaneous ventilation. B and C we are not using. Remember, for controlled ventilation, we are using Mapleson D circuit, which is also called as what circuit? Baines circuit. Okay? For pediatric cases, Mapleson F circuit, which is also called as Jackson-Rees modification. Jackson-Rees modification. Okay? Next. All are the components of barrelime except. Remember, guys, barrelime is nothing but a type of material that usually absorbs carbon dioxide. The most commonly used material is soda lime, but if soda lime is not there, then you can go for barrelime. Barrelime is made up of barium hydroxide and calcium hydroxide mainly. Okay? Some amount of potassium hydroxide is also seen, but you don't see any. You will see very minute form of sodium hydroxide, very minute, but it is mainly made up of calcium hydroxide and barium hydroxide. Okay, guys, are you with me? Are you getting this questions? Yes or no? A male patient presents for an elective total knee replacement surgery. During the pre-op assessment, the anesthesiologist performs a thorough evaluation and finds Mallampati class 3, thyromental distance of 6, sternomental distance of 13, and neck circumference of 16 inches. Which of the following would you prompt to anticipate a difficult airway? Remember, guys, thyromental distance of 6. That does not mean that the patient is having difficult airway. Sternomental distance 13 centimeters. That's also not a predictor. Less than thyromental distance less than 6 centimeters, sternomental distance less than 12.5 centimeters are the indicators of difficult airway. Neck circumference of 16 inches, no. More than 16 inches could be a predictor. But what is the predictor of difficult airway over here? It is Mallampatti score of 3. Mallampatti score of 3 means what? When the patient is opening his mouth, you are able to see the base of uvula, soft palate and hard palate. 54-year-old patient is scheduled for elective hysterectomy. During the pre-op assessment, the anesthesiologist evaluates her airway using Lemon's law, Lemon's classification, okay, which suggests that certain anatomical features are key predictors of difficult airway. Which of the following in a patient would prompt you to anticipate a difficult airway over here? Now, guys, remember, lemon is nothing but look, evaluate, Mallampatti, obstruction, and neck mobility. Okay, look for any facial trauma features, evaluate the 332 score. Okay, so Mallampatti class 2 is normal, that does not indicate difficult airway. BMI of 20 it is in a very good range. That doesn't, obese patient means they will having difficult airway, but BMI of 20, that is fine. Good neck, good range of neck movements is very fine, means that's also not a predictor of difficult airway. But a thyroid to mouth distance of 2 finger breadth, that is a predictor of the patient having a difficult airway.